Some people think it's a bit boring, you know, all the little housekeeping bit. It's the bit I like the best because I think that's where you can make the biggest difference, you know? Yeah. Does anyone have any questions? No? Anyone want to ask anything about any of those things? No? So we just talked about a few of the things in the fast hug, but when you go home today, have a look about, you know, if you Google fast hug or fast hug in bed, and when you're on the ICU, the next time you're at work, have a think, you know, maybe you already do it, but you have a think about how you can check off for each patient that you're doing all the things you should to, you know, to make it the best quality care, yeah? Yeah, so thinking about sedation, delirium, thinking about your nutrition and thinking about, and you know, DVT prophylaxis and things. Good. Finished? Yeah? Where's my clap? I'm clapping. Oh, very good. Yeah.
Hello? Can you hear? Okay. The aim of doing it together is so that we can all learn together. All right. So I'm going to start mainly talk about how we would transport ICU patients, what we would consider, how we'd plan and prepare, and then Dr. Chunga here will add in a little bit more about patients in the emergency department and what you need to consider. So, yeah, so hopefully we're just going to go through which patients we will transfer, why we will transfer, weigh up the risks of transferring versus keeping them in your hospital or in your department, and then how we prepare for that to do it safely. Okay, so why do you transfer patients? Obviously, if you're transferring from the emergency department to the ICU, of course your patient needs to go because they need more advanced care and, you know, ICU level you know, interventions, which obviously you can't keep in the emergency department. But if you're a patient in ICU, you know, some of the reasons why we transfer them out of ICU is because they need a CT scan or they need to go to theatre for a procedure. Or in some situations, some hospitals don't have everything there and they need to go to another hospital to go and have their brain operation or their open heart surgery because my hospital doesn't have it. So then I have to package my patient from ICU to be able to safely transfer to another hospital so that he can be cared for over there. Okay. So these are generally the reasons why we would transfer patients. And on the odd occasion, there might be a patient that's on holiday in a different country who has got sick over there and needs to be transferred back to their home country. So sometimes we have to do an inter-country or international transfer. Okay. Usually we're not the people involved in those. They have special teams for that. Most of us are really only going to be transferring our own patients either within the hospital or to another hospital. Okay. So, risks and benefits. What are we going to consider? And the most important thing is, why do I need to transfer this patient? What is that other place going to do? Is it important for the patient to go to another unit or to go for the scan? Is it going to help me, look after them a bit better? Is it going to give me more information about what's happening to the patient? So if that is really the really important thing, then I'm going to make it happen. Okay. But you have to always know, whenever you transfer a patient, you're going out of your environment and you're going into a new environment, which could be an ambulance, it could be an MRI scanner, where you don't have any people around you, you don't have any familiar equipment, and if something happens, it could be really messy and your patient could die. So you have to really decide, is this important for the patient? Okay, yes it is. If it is important, is this the right time to do it? Or is my patient too sick today? I might have to wait till tomorrow. Okay, and so you have to weigh up all these things. So sometimes your patient is too sick and you cannot move them because actually you're probably going to do more harm. So you have to weigh up all these decisions when you make that, a final call about transferring a patient. How many of you here have been involved in transfer of critically ill patients around the hospital or into to another hospital? Hands up. One. Anybody else? Two. Yeah, excellent. So, it's not uncommon, and so I think it's really important to be prepared and just know how to prepare. So I've talked about where we would normally transfer our patients, and now we're going to talk about, what do we need to think about. So if I give you a scenario where I've got a young patient who has basically got, has come in unconscious and has been intubated, and we don't know why this patient is unconscious. Okay, so we need to transfer them to the CT scanner. But they're also hemodynamically very unstable. Okay, they're on a lot of noradrenaline, they're on a lot of oxygen as well because they've aspirated while they were unconscious, and they're on about 65% or 70% oxygen via the ventilator, and their SATs are only 90%. Okay, they're on a lot of noradrenaline to give them a blood pressure of 90 to 100 systolic, or a MAP of 60 to 65. Okay, so you have to think, okay, how many of you think the scan is important and we must do it for this patient right now? Hands up. Anybody thinks we should take this patient to scanner now because we need to? I think so. How many think the patient's too sick to go right now? Nobody. Okay, all right. Well, the patient is sick, but we can't, if we don't know what's going on, we can't really do a lot to treat and make them better, because if this young patient has had a bleed in the brain, there's a treatment for it, which is to go to theatre. And if they can do that, she has a chance to survive. So we need to know what the problem is. Okay, so it's going to be a risky transfer because I know this patient is very unstable, but I also know that if I don't find out what's going on with her, she may not survive if it's too late. Yeah? So I need to plan. And I'm going to think, okay, I need to take her for a CT. These days, CTs are very good. And you can probably, the actual time it takes to do the scan is maybe 5-10 minutes max. Okay. So scanning is really short. It's taking them there, putting them on the table, taking them off the table takes a lot longer. So I know the scan time is short, so it's actually manageable. First thing, okay, my environment. Do I know where my CT scanner is? It's in the other part of the hospital, or is it nearby? Do I have to go up 8 flights of stairs, down a lift, down a corridor? What's my environment like? Okay, so I need to think about that. and what time of day is it. If it's in the middle of the night and it's just me, if I'm going to take this young lady to the scanner, who's going to look after the rest of my patients in ICU while I'm away for an hour or two? Okay, so you have to think about those things. But if I know that this is important, I need to get somebody to help me if I can't go myself. Okay? So, we've talked about, now I need to see, okay, she's sick. What do I need to prepare? You know, airway, breathing, circulation. This keeps it really simple. So, she's already intubated. I need to make sure her tube's in the right place, and we're happy with that. It's nicely taped and secured. I need to make sure, from a breathing perspective, I guess she's as optimized as she can be. You know, is there anything I can do to help her make a little bit better progress in that time? And I'm gonna prepare with 2 or 3 oxygen cylinders because she's on 65% oxygen. And when you put patients in the CT scanner flat on their back, often you need to go up on the oxygen. So I need to make sure I have 3 cylinders because I need to prepare for a 2-hour journey, okay? So I'm going to prepare for that. I'm going to make sure my transport ventilator, I'm going to make sure that works. I'm going to set it up, put the patient on the transport ventilator, and leave her for half an hour to see how she goes with it. And then my circulation. Does the patient actually need any more fluid? Is there anything I can do to help that circulation? And then I'm going to make sure that my noradrenaline, I've got enough of it, okay, to last the 2 hours plus extra. All right. And then I have to think, okay, you know, I think my patient's as best as she can be, and I have to make the journey. All right. Am I the best person to take her? Or is somebody else better? You have to decide that as well. Okay. So I might think that I can take her, but I also have responsibility for my ICU patients. But I have my anesthesia colleagues or somebody else who is just as skilled to take her is probably better off going, so I can stay in the ICU. So you have to pick the right person. My nurse who's going to come with me, okay, they need to be familiar with the equipment, the pumps, the environment that I'm going to take them in, okay, so they can also look after the patient. We're basically going to be doing mobile ICU around the hospital. So whoever is going, the doctor and the nurse need to be really comfortable. Is everybody happy with that? Okay. So, it talks about you need to know where you're going. Now, if it's in our hospital, most of us have been to these CT scanners a few times, so it's actually a bit more familiar. But if I'm going to another hospital, I've never been to that hospital. I don't know where their ICU is, or their theatre is, wherever I'm taking my patient. And I don't know how long the journey's going to take. So you have to make sure that the other ICU you're going to, or wherever it is, knows you're coming. You know how to get there, so the driver, your ambulance knows how to get there. And that, you know, the team that's over there is expecting you. And you don't leave until you know they're ready for you so that you can make that journey across. All right. So what has happened in the past is you leave and the team is not ready and you're waiting down in the middle of a corridor because nobody's ready to accept you. All right. So we talked about just checking the things about the individual patient. So I've gone through that already. But you want to also make sure if you're going to another hospital that you have got your ward clerks, your admin staff to copy all the notes, to make copies of the scans so you can physically take it all to the other hospital. Because now you're handing over care of a patient to another hospital who doesn't have all the pre-existing information. So you need to make sure you make copies of everything. So the minute you've made that decision, if you're going to another hospital, you have to get somebody delegated to sort out making copies of everything. Okay. Like I said, make sure your tubes, your lines, your drains, everything's nicely secured. Equipment. So I think this is probably one of the other most important things. So I've talked about making sure my ventilator works, but I need to make sure I take a spare battery. And if my ventilator fails, have I got another way of oxygenating my patient? Have I got an ambu bag or a way of delivering, at least even if I run out of oxygen or my ventilator doesn't work, I can still bag the patient with room air. Of course, my patient is going to struggle on room air because they're on 65% oxygen, but I have to still make sure I've got a backup, a plan C and a plan D for my airway and my ventilation. Okay. We often only take the one ventilator. We don't have many ventilators, so nobody takes a spare ventilator. Okay. I've got to make sure my noradrenaline and my sedation pumps, I've got charge on them, have got battery on them, okay, and there's enough drugs. Which drugs am I going to take spare? Emergency drugs. Okay. Am I going to take some adrenaline? Am I going to take some extra fluid just in case drugs? Some just-in-case drugs you want to draw up and have ready in case you need to give in a hurry. Some others you can keep, you can just take, but you don't need to open the ampules and draw them up and waste them. Okay. And that you have to decide. So this is an ICU patient. Oh, it's just lost there. So if this is my sick ICU patient getting transferred, you can imagine how much equipment you've got to look after, all your lines, your tubes, and you've got to make sure that you can put it all on the bed, you can fit in the lift with all your equipment, and you can get safely to where you need to go. That takes a lot of people. Okay, it's not a one-man job. Not one person can transfer a patient. At least 2 or 3 of you to take the patient, but then a few people to get them on and off. So we talked about drugs and standby medication. Okay, so I think we've covered that already. I've talked about that already as well. Family. You need to make sure the family know you're sending this patient to another hospital that could be an hour away. Okay, so they know that that's happening. Otherwise, the worst thing they want to do is arrive in your hospital and your patient's not there and nobody told them. Okay. Often, what I would say, so this is what we've talked about, but it's very hard to remember all these things, I'm telling you. We often have a checklist. So in our hospital, we have little checklists for patients who are getting transported to check that you have got all your equipment, your drugs, the right staff, you've communicated with the receiving team, you've got all the notes copied. So you need to make sure that all of that is done. So we have a checklist so we don't forget anything. And I would really advocate that checklists are really important, because sometimes when we're really busy and we've got so many things we're trying to do at the same time, you want to make sure that such simple things are not forgotten. And a checklist is the best way to do it. Okay. Obviously, if there's more than 1 or 2 of you going, you need to make sure who's going to do what. So usually it's me and a nurse going, and the ambulance is driving me, or a porter's taking me the bed down with me and the nurse to CT. Okay, both me and the nurse, we often know who's doing what, who's going to look after what. Okay, so I'm generally looking after the patient's main issue. She's going to manage the drugs, go up and down on the noradrenaline. She's going to watch the monitor. Between us, we communicate before we go who's doing what. Okay, and we always know who we're going to call for help before we go. So if I'm leaving my ICU, my team, my nurse coordinator knows where I'm going and knows that she will keep her phone in her hand. We have a phone with us. If we're in trouble, we know we're going to call her, and she will come down or send somebody to help us. So always make sure somebody knows where you're going, and you've got a way of calling for help when you're on the way. Okay. Yeah. So prepare, and then think about what might go wrong. And if you prepare for what might go wrong, it won't go wrong. Or if it does, it's not going to be a big drama. But if you don't prepare for what might go wrong, it's going to be a real shit show. Okay, so you've really got to think, okay, if this were to happen, have I got the right abilities and equipment and everything to sort it out? Okay, and it doesn't mean planning for every eventuality, for the key things that might happen. Okay, and that's usually, like I say, equipment failure, running out of oxygen, suddenly the CT scanner is busy or broken and you're stuck down there for a long time. You know, just figuring out how you're going to manage those things. So I've talked about that, okay, and this is really important, because if you're in the middle of an environment that you're not familiar with, you need to get help very quickly. So make sure you've got somebody. And of course, if you are going to a hospital, a different hospital in a different place, you need to check, okay, especially if it's an ambulance, because that day Zainab said she sent a patient in a helicopter with a huge trauma. Now, if I'm taking that patient in the helicopter, that patient had no face. And I'm telling you, I'm pretty scared taking that. And you have to think, okay, what's traveling in an ambulance? What's the weather like? How shaky is it going to be? Do you get seasick or air sick? If you get air sick or car sick, is that going to be a problem and you're going to not be able to look after the patient because you're just feeling really nauseous, really vomiting? Then you're not going to be the person to go, okay? So think about the environment of the transfer as well. And then, when you've done everything, do your final checks before you're about to leave the door, okay? which is, am I happy with my airway, breathing, circulation for this patient? And I've been on the transport ventilator for half an hour now. Get my blood gas. Is the patient stable on this transport ventilator? Yes. Okay. I think we can go. Okay. So just make sure you go through those final checks. Everybody's on board and you're happy before you move. Yeah. I think I've said this a few times. Communication is really important. There's usually, 2 or 3 of us traveling. If we're moving the patient on and off the table, into the ambulance, somebody's always taking care of the head and the airway. Somebody's taking care of the lines, the tubes, and then you need a couple of people to just physically move the patient. All right, so clear instructions, really clear communication. And there is no hierarchy here because we're all looking after the patient for the same reason. So it's not that only one person can do this and nobody else can. Some people are better at some things. You've got to know where your expertise is. Okay, this is important. If you are going to another hospital, okay, and your patient gets worse en route, give them a heads up if you can. Get somebody to call because you're busy to say the patient is deteriorated. I'm going to need this help when I arrive. And then when you arrive, don't just dump the patient and go, because now you're a new patient in a new facility who doesn't know them. You've got to stay and help them until the patient's stable. Then you can give a really good handover. Now, handover is so important, okay, because you're basically handing over care of the patient. You couldn't be detailed enough. All right, so it's always important to know your patient before you're going. What am I information I'm going to give them? Obviously, I've talked about giving them the notes and then checking with them. Is there anything else, information that you need that I haven't provided? And if they've thought of something that you forgot to bring with you or you didn't know, make sure you tell them. I will find out when I get back and I'll send that information across. Okay. But going through the handover is really important, and maybe Ramadan can, go through a little bit more detail if he wants about what you want to discuss in a handover. But you want to basically tell the team why the patient came in, what the problem was, what acute issues are, what you've treated, what still needs to be treated, what investigations have happened, and why your patient is arriving in this new place. Okay. Okay, so before I actually finish off, I'm just going to say, so obviously most of my transfers are of ICU patients, but I know a lot of you work in the emergency department and your transfers might be, again, to another hospital or to another part of the hospital. So, Ramadan, did you have anything more that you wanted to add from an ED clinician perspective?
Yeah, we as an emergency physician or emergency practitioner, the perspective of transfer is similar to ICU, but a little bit different because of the patient's acute situation. And all these have to be considered. And there are micro transfers as well. Having a patient on a bed, moving to another bed, that's also a transfer. Things can change. A line can come out, hemodynamic can change. And for that reason, has to be also to be considered similarly. Is it necessary to move from this stretcher to this stretcher? Is it necessary that having this person to X-ray this time is better than having, or have you actually have a slot in a CT scan before the patient go? So similar, in emergency department, those kind of things have to be considered. The other thing that I would like to highlight, and has been mentioned by Dr. Rina, is that, can you hear? Can you hear? Okay. So the other thing that we have to consider is, and I think this has been our thing that as we are looking into improving our quality, how we transfer, our history of transferring patients. And I think you are all aware, from one hospital, most of the time here we are doing intra-facility transfers. So intra-facility transfer, it means if a patient is coming from ICU, a patient is better at that ICU. When you move out of that ICU, the patient is in a very bad environment, meaning that the person who transfers that patient should be as equally the same quality or the same level of knowledge of the person who was in ICU. It's not like the same. If my patient is with Rina in the ICU or is with Dr. Lugano here, now this person is going to Moi, right? Now you take a nurse who is actually not even an intensive care nurse, a normal nurse, and the driver. Go to Moi. What are we doing? We're degrading care from a highly trained person at Benjamin Mkapa to a person who is not even a doctor, not even having the skill, because the reason is, as Rina mentioned, during transfer, anything can happen because of the turbulence of the transport, because of the changing of the environment. For example, sea level is not the same as if you go to high altitude. Similarly, when you're in a road transfer, our roads are not even. So the same thing. So you cannot have a person who is underqualified to transfer a person who is critically ill, meaning that this is where we have to be looking at. Again, a doctor is not designed very well to treat a patient in a moving car. We are not designed the same, meaning that there are people trained. And this is where we can look at having people who are paramedics are actually trained into working in those kind of extreme environment. I don't know if, Dr. Rina, you can work well on a fast-moving vehicle.
Not so well.
Yeah.
Well, definitely not thing where you... But definitely not if I have to intubate a patient, I have to get the ambulance to pull over. You cannot do those sorts of things with a fast-moving ambulance.
So you see, even the best expert, they're not good at a fast-moving vehicle. And this is what the other thing that you all understand where to look at. So a very sick patient, you can't be running at 120, running to the other hospital, because that also put the patient in danger. Anyway, she mentioned a lot of things, and I could say, as long as the patient was admitted in the ward, as long as the patient was admitted in ICU, it is equally important, this patient's care to be of importance when you transfer. And all other things that have been looked at, including the indication, have been exhausted, including the risk and the benefit. Why are we sending somebody GCS of 3? Let's say somebody GCS of 3, and you know, if you call to Moi, there is nothing they can do different. Why are you anyway moving it to Moi? Similarly, it can go down to our lower centers. If there is nothing that can be done differently, why are we moving? Because moving is even riskier. So sometimes discussing with the receiving facility, they may give you guidance, because they will say, okay, that patient, based on how the situation is, I think is better managed there than, or maybe sometimes they can even consider giving you an alternative way of transfer, because some patients are better transferred by helicopter, some patients are better transferred on the ground rather than on air, some patients are better transferred on air than on the ground. So for that reason, then, and with that remarks, I think Rina has exhausted many things. Perhaps you may want to add a little bit and a few questions. Please, Doctor.
Actually, to add some more. You know, Dr. Rama and my colleague, sometimes we evacuate the patient, not transfer the patients, especially for lower facilities. I came from the peripheral regions where the nurses and doctors from the peripherals, especially these dispensaries, they just evacuate the patient because they don't like to stay with patients. And you may find sometimes even the nurse who escort the patient don't know the history of patients. When they came to our area, maybe sometimes when you ask why this patient came, I don't know, they told me to send the patients. It's just 1 week ago when I received a referral from different areas. The nurses came with patient, no cannulation, patient has no catheter, stroke patients. Actually, I was amazing. Even I brought that nurse in my office and talked together so that we can do that one. And remember that our settings, we don't have a complete ambulance. We have the car for transfer the patients. So sometimes if we don't prepare ourselves to transfer the patient, we may find that the patient transfers for low distance, then you get died on the way. So we have to make sure that we know the patient before we transfer. Sometimes we have all equipments needed for our patient to transfer. We normally transfer our patient from Songwe to Mbeya. It's almost 70 kilometers. You may find even the nurse don't have any equipment on the way. Kwa hiyo tuwe makini. Kwa hiyo tuwe makini sana sana. Wauguzi wenzangu, nisisitize sana hapo tena niongee kwa Kiswahili kabisa kwamba wakati mwingine tunapowasafirisha wagonjwa tuwe na critical thinking kwamba this patient kweli anainidi kwenda mahali pengine, ni nini hasa tunachokwenda kukipata. Tunaenda kummaliza huyu mgonjwa au tunaenda kumuokoa? And sometimes these obstetric issues, you may find the nurse and the doctors transfer the patient who has a massive bleeding on the way. How will you resume this patient? How will you make sure that this patient will stop on the way? Kwa hiyo tuhakikishe kabisa kwamba tusiwa transfer wagonjwa wanao bleed. Indeed, it's our protocol in our regions, even the RMOs say that no transfer of patients who are bleeding on the way. And sometimes the gynecologists, they have to go to the settings and teaching them to capacitate the staff so that they will not transfer the patient to another hospitals without the thinking. Thank you.
Any other comment from the participants? Dr. Zainab, you want to speak something, perspective from Zanzibar, please? Perspective from Zanzibar?
Hello. I think my colleagues have already spoken a lot about patient transfer. And in our part in Zanzibar, we are lucky enough, like we have our hospitals nearby. So the similar challenges that you guys are facing, that sister there has emphasizes, we are also facing the same, but we're on the path of improvement. So I'll try to highlight it also in Kiswahili. Most of the time we panic, especially our junior colleagues. I know when you get a patient who is critically ill and then adrenaline just goes high and you're like, okay, maybe sending the patient to the next hospital will be saving the patient. But unfortunately, most of the times, you're actually handing in a death certificate to that patient. Because as long as the patient is within the hospital, you are more than capable of helping that patient compared to transferring the patient. And we know most of the time we're short-staffed. So the person who is transferring that patient is not really as capable as you are to transfer that patient. So we end up short-changing our patients because we feel like maybe whatever I'm doing here is not good. But maybe that little that you're doing where you are doing will be life-saving for the patient. So again, as what my colleagues have said, we are really emphasizing proper transferring of patients. It's very important. Thank you.
Thank you, Zainab. Some really good points made, and I guess that's obviously something really important for your area and knowing. And I guess it comes down to the first part, making a decision about is that patient benefiting by going or more harm. Okay, and sometimes we have to weigh up the problems, and against and decide. But it seems like obviously largely there is a lot of harm from transferring the patient to another place if there isn't anything more they're going to do differently. So you have to really think about it. I mean, everybody's always going to be anxious when you have a really sick patient, and sometimes you think it's out of your depth or capabilities. But I guess that's really a decision you have to make with the team around you, knowing what you're able to do. Any other questions? Any other thoughts?
I like being practical. And I've worked many years in the hospitals to have a little bit of understanding. Transferring a patient. You are in the periphery. You want to transfer the patient. Why do you want to transfer the patient? You must have an answer for that question. Why am I transferring this patient? Is it because I can't handle? Is it because beyond me? Is it because I don't have the equipment? Is it because I don't know what is happening to the patient. You've got to have an answer before you transfer. Now, our friends in Morogoro recently, they had problems when they had that tanker was busting and they had a number of blunt patients. And colleagues of mine were saying, this one, Muimbili, this one, Morogoro, this one, Muimbili. So they are doing triage, which is correct. And then came a politician. And you are right, you guys. This man is 60% burnt. You're saying Morogoro. And this 20% to Dar es Salaam. You understand what I'm trying to say? For him, the worst burnt should have been not going to Dar es Salaam. But that's not what trauma says. A person who is 60% burned with 60% burn is less likely to survive. You don't want to waste the resources on such a patient. Morogoro. Guy with 20% is likely to survive. He goes to Muimbili. The stress is slightly different. So you need to understand what you. If you put a patient who has a cardiac arrest, you recognize it's a cardiac arrest, and you put him in an ambulance, you're killing him. You're sending him to the grave. He doesn't need that ambulance. We need to decide as to who should and should. If a patient is bleeding, actively bleeding, and arterial bleed, and you put him on an ambulance and you put pressure bandages, you're killing him. Are we together up to there? Think, like what my colleague said. Think before you put that patient on the ambulance. You might be actually killing him instead of saving him. But if the patient is stabilized, and you put him on an ambulance, it makes sense. It makes sense. So don't transfer unless you know what you're doing. Don't transfer unless you have stabilized. And don't transfer conditions that usually are lethal, even in the best of hands. Kwa sababu unajaribu kupunguza ile mortality ya hospitali yako. Isionekana wanakufa wengi sana na mikononi mwako. Otherwise, the ministry will start asking you, why are there too many deaths in your hospital? Benjamin, mwacha kafe Benjamin Mkapa. The statistics goes to Benjamin Mkapa. The other practical element is the ambulances, sio ambulance. Kama alivyosema sasa, ni kubeba watu from point A to point B. Unamwambia nurse, kupeleka mgonjwa Benjamin Mkapa. She sits in the front seat with the driver. So who is watching them over the patient? It is happening every day. It's not something that I'm sure even in your hospital you have seen. The sister sits with the driver. Effectively, the patient has no observations of any nature. There is nobody looking after that patient. The sister is taking a ride. Akifika kule, when you ask the sister, so how is the patient? Does he know the history? Does he know the progress? She can't help you in any way. This is why when we teach trauma in our setting, we teach trauma as if the patient has never been to any medical institution at all. Kwa sababu vile hawajapitia hospitali yoyote. They are green. They have never seen a medical person at all. So when we are teaching management of traumatic patients, we always teach the pre-hospital one. Pre-hospital care. The first 10 minutes, what do you do with that patient? That's why we are heading that direction, because we realize if you wait until the patient gets to the hospital, the patient is decompensated or already dead on arrival. So let's take this matter very seriously. It looks like it's a very simple lecture, but it's not. It's not a very simple lecture, because it's got a lot of stuff in it. And there will be politicians who will come and harass you for sending for not sending or for sending somebody to another institution. You've got to have answers for the politician, and for me, answers for yourself than in the next hands, pair of hands. I can continue.
Thank you very much. Okay, I think we'll end the session there. Very good. Did you want to say something, Maynard? Okay. Well, we finished, but you've got 1 minute.
It's a deep subject. Point out a few of the things that actually you need to go deeper in it. Number one, I had a discussion with one of the flying doctors in here concerning a patient on a mechanical ventilator and a patient with on oxygen cylinder. Which one will have more oxygen consumption? And I actually told him that there's a formula for that. There's a patient who can be on a mechanical ventilator with a FiO2 maybe of 50%, and you have a patient with an oxygen cylinder maybe 15 liters per minute. The patient with oxygen cylinder 15 liters per minute with the first mask reservoir will actually use more oxygen compared to the one on a ventilator. So there's a formula for that. You can consult me on that. So it used to be a very challenging issue, especially during the COVID times, because we had people transporting patients far away from all the regions to Dar es Salaam on oxygen cylinders, and they used to end up on the way, running out with oxygen on the way. Yeah. So if you're not well prepared with a lot of calculations on how to transport your patient, it's going to be challenging on your journey. Yeah. Another thing, something that maybe some of you might actually not recognize. Sometimes patients arrive at hospital, they are dead. Meanwhile, during the transport, they were alive. So you see, there's a bit of physics to it. Third law of motion. To every action, there's an equal and opposite reaction. So now, for example, you have different patients. For example, you have a patient who's hypertensive, a very hypertensive patient. Maybe you might need some vasopressor to actually support the patient. So you have your ambulance. So the patient is sleeping in the head is actually, the patient is like this and the ambulance is like this here. So the head is, the legs are facing towards the door and the head is facing towards the driver. So you have this ambulance going like this. So this is an acceleration motion, yeah? So this is the motion going like this. So the opposite motion will be going backwards, yeah? So now you have an ambulance with a 120 speeding up. So going like this, the opposite motion will actually be displacing organs and blood and fluids to actually opposite to how the ambulance is going. So the car is moving fast, and now everything is moving backward fast. Yeah? So you have your blood pressure, your blood flowing, going away from the brain, going towards the legs. You understand my point? So now you are decreasing perfusion of your patient towards the brain. Everything is being displaced towards the legs. And now you have an hypertensive patient who is actually deteriorating more with an ambulance that is actually going very fast. Because drivers know that an ambulance needs to go very fast. But that's not the point. An ambulance just needs to have a steady motion, a constant motion, maybe like 60 kilometers per hour. Now, the same applies that whenever an ambulance decelerates really quick, when it goes like this, and then it decelerates, so now you have another opposite reaction. So now your organs and everything is displaced towards the patient's head. So you're exposing your patient to the risk of vomiting, aspiration, increase in ICP, especially when you're transferring a patient with a brain injury. Yeah, so eventually, the way you're transporting a patient with an ambulance, that you're speeding up and going back and forth until you reach the hospital, the patient is dead. And you actually don't know why that this patient has died. Yeah, so those are some deep topics to it. And as Dr. Fire said, that it's a very deep topic. We really need to stress upon this. Thank you.
Thank you. Okay, we're going to close the session here now. So I think the nursing group are going to carry on with their teaching that they were doing. I think they're halfway through nutrition. So if you want to head back to your little room, your big room, down in the training centre, and we'll doctors group back into our training centre as well for some workshops. Okay. Good. Thank you.
Let's use 5 minutes, guys.